So thank you to everybody who's here. We will continue to let folks in through the Zoom room through the waiting room as they come in. But we'll go ahead and get started. We want to leave as much time for our two presentations as possible. We have a great presentation today on trauma-informed initiatives in the healthcare system. And so really excited to have East Tennessee State University, Dr. Schetzina, as well as Dr. Shnaki Mal and Scott from CityBlock Health. And so really excited for the presentations. But beforehand, as we always do, a few updates from what we know is going on in Congress. First of all, the appropriations process has gotten pushed back to December 3rd. We are anticipating potentially another continuing resolution, but hope to have some of that great language that was in both the Senate and House appropriations bills for trauma-informed practices in essentially what comes out of both the House and the Senate when there is an agreement. And so, we presented on that. We have a link on our website, which I can put in the chat a little bit later. If folks are interested on the House language, we did a summary on some of the great report language and funding streams that would be made available through the appropriations bill, but there has not been a final appropriations bill passed to date. The other thing that we have really been doing a lot of work on is around the reconciliation package, the Build Back Better plan. There was $5 billion in President Biden's Build Back Better plan that was for addressing community violence and for community violence intervention programs. There was, that essentially got split into two different funding streams. One was in the judiciary and really has remained around community violence specifically and violence intervention programs. The other $2.5 billion from that community violence intervention package was referred to energy and commerce and help. And that $2.5 billion has stayed in the reconciliation package, all $5 billion through the cuts of the reconciliation bill. That $2.5 billion for energy and commerce and help has stayed in and really mirrors Section 101 language from the Rise from Trauma Act. So it would create a new grant program for communities, states, tribes, and other organizations to continue trauma-informed work, creating community coalitions. As folks who are regulars to CTIPP and in our trauma campaign, members of our trauma campaign, you know that one of our top priorities is the development of community-based trauma-informed coalitions, and that we really want to empower communities to come up with best practices that work for their communities, given the resources, the needs, the populations you all serve. And so we are excited to see that $2.5 billion has made it through the reconciliation process to now. Now it becomes a function of, will reconciliation pass? While we've heard that it is possible, probable, we don't know for sure. And so it is still a waiting game, but that $2.5 billion has remained, and that shows that this is a priority for the administration, for Congress. And so that provides good legwork moving forward. The one thing that I want to say before I move on to some next reports is that we continue to see the priority around creating trauma-informed healing and prevention focused, resilience focused, and community-owned health and well-being strategies becoming more and more of a priority at the federal level. And it is as well as states and in communities. And it's important to note that the work that the trauma campaign has done, we certainly can't take all the credit for that, but making noise, having that groundswell of support and all of the work that you do in creating relationships with your elected officials' offices has been huge and continuing to grow that support at the national level, as well as what we're seeing in multiple states and in various communities around the country. And so thank you to all who are a part of the trauma campaign, who have helped by spreading the word, developing those relationships, communicating those calls to action. There is a lot of hope and reason to be inspired heading into 2022 that we can continue to cultivate support and work toward further appropriations for FY23 and more resources and supports for communities moving forward. Beyond that, two big things that CTIPP has been working on outside of just the policy arena that we want to be able to send and make you all aware of now. One I have just put in the chat is a workshop series that is going to begin on January 7th, and it will be every other week on Friday from 1 to 5 p.m. Eastern time. And it is all around building a national movement to create trauma-informed and prevention-focused strategies throughout the United States. And so the first session will be all around community coalitions, and then we'll dive into some sectors. We will dive into from there specific strategies and promising practices. We will get into a global outlook on major crises that our world faces today, and finish with a policy and advocacy workshop. And so those 8 workshops in the series are all free. We invite everybody to sign up. We have had some incredible partners hosted by CTIPP and the National Prevention Science Coalition, along with several other organizations. We ask you to sign up, share that information with others. This is the first of hopefully many workshops and conference. This isn't a conference. We intentionally didn't do a conference in this virtual world. We didn't want to continue to wear out people's Zoom fatigue, but hopefully we can move into conferences and continue to build the movement through strategies like this moving forward. So again, that link is in the chat. Please sign up. Please share that with your networks as well. We are really, really excited about this being the first annual workshop series and are excited to see how this grows and where we can go moving forward. The other thing that CTIPP has been working on in concert with the Center for Educational Improvement and a few others through the Coalition on Alleviating Child Trauma is a new podcast about trauma in schools to really increase awareness about trauma-informed educational practices that was just released. So you can, and I just got a note for our workshop series, a few of the key sponsors that you can see on the website that I shared are PACES Connection, the National Youth Employment Coalition, like I said, National Prevention Science Coalition, and CTIPP. You have the Center for Trauma Resilient Communities and others. And so we are grateful to all of our sponsors in this work. Again, we will continue to update that sponsor list for that. For the podcast, we are really looking to emphasize the importance of trauma-informed educational strategies. And so we are talking to students, teachers, principals, those who work in nonprofits and other agencies that support schools. We have a conversation with someone at the state level, and those episodes, there are currently 7 released, and they will continue to come out. We have 38 in the can, and so they will be coming out weekly through May. And so wherever you get podcasts, rather, Spotify, Apple Podcasts, I believe that it is posted elsewhere. Please follow, listen along, share with others as well, especially around the opportunities that exist with ESSER funds, the Elementary and Secondary School Emergency Relief Funding. That was really the impetus and genesis for doing the podcast. And so we are excited about this, want to make sure that it reaches more ears and audiences as possible. And so again, the website for that is in the chat. And the last thing that I will highlight before moving along to our wonderful presenters is that it is November, and in the nonprofit world, that means that Giving Tuesday is this month. For those who don't know, CTIPP got a very generous gift this past year, And we are working toward building our first full-time staff. So we are looking to expand our team going into next year, which is very exciting for an organizational front. But as Giving Tuesday comes up, if you're able to, I put a link in the chat where you can donate for Giving Tuesday. If you're not able to donate, we understand. But sharing this opportunity with others and continuing to promote, we are a 501c3 nonprofit organization. We rely on donations. We try not to use these opportunities to, ask for fundraising. We really appreciate all the advocacy and support that we get in so many other ways from all of you. But with Giving Tuesday coming up, wanted to use this opportunity to really highlight this as an opportunity to give, and CTIPP as what we certainly believe as a worthy organization and cause to give to. So thank you for both of those. One other note that I just got in the chat is that in the appropriations bill, the Federal Interagency Council or Task Force on Trauma-Informed Care prepared their recommendations for how federal agencies can work together to prevent and address trauma. So we continue to expect more to be coming out of the Interagency Task Force. They, in the appropriations bill, have $1 million, which is the first time that they've been funded since they were created through the Support Act. And so we will continue to monitor and provide more insights as we move forward there. So those are our updates. I will follow up again with the links that I discussed in the chat box. But moving forward to our presenters, we are going to start with Dr. Karen Schetzina, who is a general pediatrician, epidemiologist, professor of pediatrics, and director of Child and Family Health Institute at East Tennessee State University. She currently serves as a chair for the Leadership Council for the Strong Accountable Care Community in Northeast Tennessee and Southwest Virginia, and is a founding member of the Strong Brain Institute. The purpose of this presentation is to describe pediatric primary care, academic and community-based trauma-informed and resilience-informed initiatives in Northeast Tennessee. Evaluation of these initiatives, relevance to other settings, and recommendations for sustainability will also be discussed. So Dr. Schetzina, with no more from me, we are very excited for your presentation. Thank you for being here, and the floor is yours.
All right, well, thank you so much, Jesse, for that introduction. And I have a few colleagues here on the call today that I've seen, and Miss Becky Haas is one of those, and she actually extended the invitation for me to speak to you all today. So I'm going to go ahead and share my screen and just really appreciate being able to talk to you today. Okay, so as Jesse mentioned, I am going to focus my comments on trauma-informed healthcare systems. And East Tennessee State University is located in Johnson City, Tennessee. We're about 4.5 hours east of Nashville, and it is a beautiful fall day here in the foothills. Jesse did a great job introducing me. I am a general pediatrician and am going to tell you a story today. Storytelling is a strong tradition in Northeast Tennessee, and while I am not a native of the region, I grew up in the Raleigh-Durham, Chapel Hill area of North Carolina, and then did my pediatric training and early practice in the Bay Area of San Francisco. I have called Johnson City home for the past 18 years. So I'm going to embrace storytelling and just let you know that there's so much, as you all know, going on nationally in our state, even in our region. And this is not intended to be comprehensive. It's really just my from my little corner of the world. So forgive me if I leave anything out or am inaccurate anyway. So just a view from a general pediatrician in Northeast Tennessee. Jesse described the purpose. Again, I'm going to touch on primary care, in particular pediatric primary care. I am an academic pediatrician, so am an educator and sometimes researcher, as well as a clinical care provider. And at the end, hopefully, as well as throughout the presentation, I'll share some lessons learned and things that hopefully will be relevant to everyone here. So our story begins in the ETSU Health Pediatric Clinic in 2009. So our clinic, like many academic centers, serves a population of children and teens who face economic and educational challenges and barriers. Approximately 80% of the patients that we serve are insured by TennCare, or state's Medicaid program. And back in 2009, one of my colleagues, Dr. Jody Palaha, who is a clinical psychologist at ETSU, worked with our pediatric program director at the time. So at ETSU, we do have the Quillen College of Medicine, and we also have a pediatric residency training program. They worked together to establish a team-based integrated care program in our general outpatient clinic. And this started with a small grant from the American Academy of Pediatrics and a clinical psychologist being present just for a few hours, a couple days a week in our clinic. And those are pictures of our former trainees, both from psychology and from medicine and pediatrics. And of course, Dr. Palaha's goals with this program were not only to improve and serve care for our patients, but also to help train providers in this model of integrated behavioral health care. So you can see in the photos that, of course, the way this works is that as our nurses and pediatric providers see patients and we identify potential behavioral health issues, we can just curbside, walk down the hall, find our behavioral health consultant, say, hey, could you come in and talk to my patient? Here's what's going on. So we primarily functioned through warm handoffs. And as opposed to traditional mental health, this model of integrating into primary care services is very effective in increasing reach, while the dose of mental health services provided in this model is much smaller and it consists of brief interventions. The reach and engagement is improved. So I was working primarily as a pediatric hospitalist at the time, taking care of sick kids in the hospital. It was really starting to wear on me. I'd never in my training seen so much child abuse and neglect or in my prior practice. And of course, as a hospitalist, I often end up seeing the most severe instances, kids who had to be hospitalized due to injury or for safety reasons. And so fortunately, I was able to begin a transition in my career to do more outpatient community outreach and engagement and prevention work. And that was really part of my motivation. So I have a timeline here. And this first part of my talk is going to focus on our pediatric primary care clinic. So because of the existence of this multidisciplinary team in our clinic, we began developing projects, and you can see those over the years. We've done lots of projects together. The one I'm going to talk about next is Read and Play for a Bright Future. So Read and Play was actually developed to have 4 areas of focus: play more, play together, fuel to play, and play safely. We have some really talented graphic designers in the College of Medicine at ETSU. So we worked with them, as well as a broad range of stakeholders in our community, to develop some tools really aimed at engaging our families in rural regions, and particularly in the population that we serve. Building trust is really important and not always easy to come by. So we developed a collection of books and other resources that we would give out to families when they came for checkups, partly based on our experience with the Reach Out and Read program in our clinic previously. Over the years, we also developed an outreach component, and multiple times a year, we would actually go with our providers, our trainees out in the community, and host support groups or community events where we could reiterate some of the things that we like to talk about in well child care. So, how to help your child thrive and develop, how to create safe, stable, and nurturing environments at home. The example of sharing books with your child, what a great opportunity to foster those serve and return interactions. So really just trying to support caregivers, and then build peer support and foster a community of health in our region. So the picture on the top right-hand corner, I think, was our last community event prior to COVID-19. All stories have to have a villain, and that's one of the villains in the story, of course. This outreach really had to come to a halt at the beginning of last year. We did have a small break this summer when we were able to do a little bit of community outreach. The lower photo is at a drive-through event that we did with one of the local health departments, and you can see one of our residents there wearing a mask. This program has been sustained through a number of different grants, funding from our state, funding from the American Academy of Pediatrics, HRSA grant, as well as from our regional hospital system, and just really has become institutionalized for us. Moving forward to 2013, again, because of the existence of this integrated care team in our clinic, and recommendations from our academy that pediatricians should start thinking about identification of postpartum depression, we embarked on another project. And I think too, with our experience with the Read and Play program, it was great, but we still recognize that our families, our children, were still facing a lot of adversity in their lives. From their environment, from lack of resources, and from behavioral health issues. So I'm going to talk about this period next, from 2013 to 2016. Shortly after we began screening for postpartum depression, we were also able to integrate a social worker into our clinic. And as a result of that, we kind of broadened our focus beyond postpartum depression screening into identifying and screening for unmet social needs as part of the social determinants of health effort. And again, it was really helpful to have these other professionals integrated into our clinic to kind of hold our hand as pediatricians. It was pretty scary initially to talk to the moms of our patients about symptoms of depression or even risk for suicidality, right? We were doctors that took care of kids, not adults. But again, with this team-based integrated care approach, we're able to do this. So we actually ended up using, of course, the Edinburgh screener for postpartum depression, and then adapted the We Care screener, which is a screener I'd heard a presentation about at an American Academy of Pediatrics meeting created our own team care screener based on that, again, an adaptation, and began administering that at well child visits. And our behavioral health and resource team was then able to receive handoffs from the pediatric providers when behavioral health or unmet social needs were identified. And you can see on the right a tool that team used called the Eco Map to look at not only issues or challenges in a family's life, but also strengths. If you see on that Eco Map in the upper left-hand corner, there's a little circle for mental health, circle for home safety, where medication lockbox is kind of highlighted. So, you know, during this time, the other thing that we were seeing in the nation, and in particular in Tennessee, was an increase in opioid use, drug use disorder. In Tennessee, we saw a 10-fold rise in instances of neonatal abstinence syndrome resulting from prenatal drug exposure in babies, you know, since the early 2000s, increased 10-fold. So again, as we started asking these questions, working with our behavioral health and social work colleagues, we just developed more and more awareness. So moving on to 2016, I want to step back and talk about things that were going on in the state. So Building Strong Brains is Tennessee's ACEs Trauma and Resilience Initiative. And the goals of this initiative are to increase education and awareness about ACEs trauma and resilience, also to positively influence policies in the nation, in the state, and locally. And they also began offering grants. And so that they were helping to support innovative and promising practices in local communities across the state. And so with this past experience, and in particular with concern about the drug use epidemic that we are experiencing in Tennessee, and especially in our region, and the impact on our kids and moms, through the Department of Pediatrics, we applied for one of those grants for Building Strong Brains. It turns out several colleagues at ETSU and in our region also applied and were funded. So I mentioned Becky Haas at the beginning of the call, and I first met Becky through the ETSU Institutional Review Board. I served on that, and she was a coordinator for our IRB. So I knew her as IRB Becky. Around this time, we reconnected. She actually was working for our local police department, which was I was a little bit surprised about, but she really had become a leader in our region in terms of increasing knowledge and awareness of ACEs and trauma-informed practice, and had begun conducting trainings throughout the region with another colleague of mine, Dr. Andy Clements. He's a psychologist at ETSU. And I had the opportunity to participate in one of their trainings and then also get trained as a trainer. So of course, the state of Tennessee was also doing this work. I know Becky and Andy's training drew a lot from SAMHSA training materials. And then of course we had Building Strong Brain education available in our state. And I have to say that's really when everything started to fit together for me. And I really started to understand the impact of early adverse childhood experiences. So going again a little forward in our timeline, I'm going to talk briefly about the grant project that we had from Building Strong Brains Tennessee. So, and then at the bottom, there's a little reminder for me to talk about value-based care contracts. So at baby steps to success, what we did is we developed a protocol for screening for ACEs in our general pediatric clinic. And we focused on families with children in the first 5 years of life, so young kids, and did this as a pilot. We were able to continue to do warm handoffs to our behavioral health and resource team, which had expanded. We actually had full-time coverage by this point. We became to recognize, and our leadership came to recognize, that it was so essential to have this integrated care program that the institution began to support it and fund it. And we were actually able to get some additional support through our state Medicaid agency through a value-based care contract. So the other components of our screening program that we added through funding were partnerships with a local mental health and drug use treatment provider in the region called Families Free, and with our regional health office. We were able to begin offering some parenting education and support through evidence-based curricula, including Incredible Years and the Well Child visits, and then nurturing parenting through partners in the community. And we're able to do some care coordination for families who were experiencing adversity identified through our screening, as well as for parents or caregivers who were expressed that they were still, it felt like they were experiencing effects from childhood adversity that they'd faced, and were able to link to some home visiting programs. So our integrated behavioral health teams, to develop all these projects, we began forming what Dr. Palaha has coined champion teams. So we get everybody in the office or in the community that we thought was a relevant stakeholder, and like that's how we would come up with our plan, just a small champion team. So we decided to use the ACE-Q screener. We did adopt that somewhat to screen for ACEs in our parents and caregivers, and then by proxy for our kids, and that's from the Center for Youth Wellness. This is just a handout that our champion team developed. So when our nurses provided the screening instrument, they also talked to families about why we were asking these questions and provided this handout. And I have a link in the slides to a publication where we summarized our evaluation of this pilot. One thing that we found is that among parents and caregivers of young kids in our clinic, 37.5% reporting having an ACE score of 4 or higher. So that's significantly higher than, rates that had been reported statewide, almost double. And that really didn't surprise us. I can tell you as well, for those young kids in the first 5 years of life, over 9% had a history of 2 or more ACEs. So we did have really positive feedback from parents and caregivers. They really were interested in learning about ACEs. They were interested in the parenting support. We also use screening as an opportunity to remind ourselves, oh, books are a great way to serve and return with your child. Just to remind us, it's really important to talk about Reach Out and Read. It's really important to engage families in our read and play programs. Then, we collected feedback from families about the appropriateness of doing this in the clinic and helpfulness, and it was really positive. Unfortunately, we ended up with only 1 year of funding, and we're not able to continue all of the services, including the home visits and parenting programs. And a lot of our families were really disappointed and said, "Are you sure?" Fortunately, we persevered, we were resilient, and were able to continue to develop services based on this experience and get some additional funding. Some of that was from value-based contracts. We also received grants from, again, the American Academy of Pediatrics and our regional health system, and now have a program that started at the beginning of 2020 called Baby Steps. And it is a perinatal care coordination program, as well as a follow-up clinic for infants and children who were exposed to drugs prenatally. And so the goals of Baby Steps is to create a recovery-friendly medical home. And we've actually recently been recognized by the American Academy of Pediatrics as a promising practice. You can see on the left, we have a large team just with the recognition that there are associations between prenatal drug exposure and risks for developmental delays and other health issues in children. We also know that, of course, women who are in drug use treatment, over 70–80% have a history of trauma. We know that from research. We know that from talking to women in our region. And of course, having someone in your household, a caregiver with drug use disorder, can itself put you at risk for adversity and trauma, right? So, and we know with ACEs and trauma that increases children's risk for developmental delay and other issues. So we have in this follow-up clinic occupational physical speech therapy, we have nutrition, we have lactation, we have counseling. Our Diana Pure is our medical director and pediatrician for the clinic. We again were able to integrate some community providers into the clinic. The picture on the right is a room we call it the pop-up party room, where again, Families Free, who's a licensed mental health and drug treatment provider in the region, is with us in clinic to do sort of a warm handoff to their programs and services in the community, which range from, light touches to very intensive programming and wraparound services. And you can see we really tried to create an environment that's welcoming, fosters that sense of psychological safety, and facilitate engagement. We now also have early intervention integrated into our clinic, and had planned to have the health department and the regional health office integrated in to help with things like the WIC, connecting people to WIC and home visiting programs. But again, that villain, the COVID-19 pandemic has limited their participation so far. So that was a happy ending for Baby Steps. I'm going to rewind just briefly back to 2018 and talk about the Brain Trust. I mentioned that there were several colleagues and individuals in our region who ended up getting one of those Building Strong Brains grants. And then through Becky Haas and Dr. Andy Clement's trainings in the region, a group of us got together with this common interest around ACEs, trauma and adversity, and began meeting, and we called ourselves the Brain Trust. So this was a good opportunity for me to get out of my silo across the street at the hospital and clinic, come onto our main campus, and get to know some of my other colleagues. And these were people who, again, were educators, were scientists, and we started meeting and talking and saying, well, what could we do? At the same time, Becky Haas became the trauma-informed care coordinator for our regional health system, Ballad Health, and continued to participate with us in these discussions with the Brain Trust. Well, one day, we received a call that ETSU was receiving a $1 million gift from our regional health system, Ballad Health, to start the Strong Brain Institute. And Dr. Wally Dixon, who is on the call, who's chair of psychology and has played a strong leadership role in administration in our institution, was named the director of the Strong Brain Institute. I know one of his particular interests was fostering trauma-informed practice at ETSU and making ETSU a trauma-informed institution. So our institution, and particularly in health professions training as well, our mission is very much to serve the region and to train our regional workforce. We have folks as a state institution that are coming from the region, and we want them to stay and go out into the region. We want them to be successful, and we want them to be trauma informed. So as established in early 2020, the goals of the Strong Brain Institute were to promote awareness and understanding of ACEs, disseminate evidence-based practices for preventing and mitigating the negative effects of ACEs, and promote a trauma-informed citizenry and workforce, including health professions workforce. Just a little bit about the Strong Brain Institute. Our brain trustees became the steering committee, along with some other associates that we've gathered along the way. This is a very interprofessional effort. We have individuals representing 11 academic departments from all 8 of ETSU's academic colleges. We do have an advisory council that includes leaders from regional community organizations, institutions, and agencies, and that includes students. And starting out, we initially had 2 teams, one for curricula and one for institutional transformation. So just briefly, what we've been doing since then, you really cannot throw a rock and avoid hitting someone who's having a conversation about the Strong Brain Institute. It's really taken off. This group has been grant writing, doing research, publishing, coordinating efforts in our region and beyond. There's links to our website embedded in the slides, which I'm happy to share. Dr. Dixon administers a listserv called CURE, which is Colleges and Universities for Resilience. Our group also does consultation in the institution and the region, for example, working now with a rural local school system in Southwest Virginia. And then we're continuing to expand on training with Becky Haas, Dr. Clements as part of the Institute, as well as our multidisciplinary colleagues. And so you can see there are a couple badges from our training program. So in the last part of my comments, I wanted to talk a little bit more about our community. I mentioned that our regional health system, Ballad Health, which was created as a result of a hospital merger back in 2018, provided a gift that established the Strong Brain Institute. And I think, you know, from these efforts that from the state and in our region to expand education and awareness of ACEs, our leadership became more aware. And that's really what facilitated this gift, establishing the Strong Brain Institute. As I mentioned, they do have a trauma-informed care coordinator. The service area for Ballad Health is Northeast Tennessee and Southwest Virginia, a 21-county region. And following this hospital merger, they created a Department of Population Health at Ballad Health, again, with some leaders who were very informed about ACEs resilience and trauma-informed practice. And the other thing that Ballad Health has done since then is serve as a backbone organization for the Strong ACC. I'll just tell you a little about that. Strong stands for Striving Toward Resilience and Opportunity for the Next Generation. Accountable care communities are cognizant of the importance of the determinants of health, right? So we spend a lot on medical services, but what really makes us healthy or unhealthy are health behaviors, as well as environments and genetics, as well as access to care. And it's really those healthy behaviors and environment that contribute most. So, an ACC intends to impact population health by integrating this knowledge and engaging not just healthcare, but public health, social services, businesses in a community, and build multi-sector partnerships to address not just health system factors, but social and economic factors, again, with the goal of improving population health. So this is a snapshot of our Strong ACC. It does cover Northeast Tennessee and Southwest Virginia at its formation. I believe it was the only accountable care community in the nation that spanned 2 states. We have a 24-member leadership council with representation from both Tennessee and Virginia. And I serve as the chair of that leadership council. We have now over 300 member organizations from health and healthcare sector, education sector, community and faith-based organizations and businesses and other organizations in this region participating. We are using the collective impact model. So we have worked together to identify a common agenda, shared measurement, plan to implement mutually reinforcing activities. Sorry. Whoops. I'm trying to move my Zoom controls around so I can read my slides, and sorry about that. Our goal of continuous communication, and then I mentioned the backbone support from our regional health system. When we first got started back in 2018 and even before, we did regional focus groups, crosswalk to community needs assessment, and engaged multi-sector stakeholders. The group started out with 3 priority initiatives that include substance abuse and misuse, tobacco use, and overweight and obesity. But because of this process, a 4th was added, and that was childhood trauma and resiliency. And ultimately, our overarching strategic focus for the Strong ACC is to build regional resilience. We have continued work initially in sector committees and with the Leadership Council, and now in working groups. We identified a large list of initial priority initiatives. Again, many were related to ACEs, resilience, and trauma-informed practice. We did narrow and focus our list due to COVID-19, but have all of these working groups and subcommittees functioning now with member organizations to develop a community data dashboard to help us with communication awareness and evaluation of initiatives, a no wrong door care coordination initiative to further expand ACEs trauma and resilience training and practice in the region, do workforce training and life skills training, expand our behavioral health workforce and integrated care. We also have a focus on early care and education. And then of course, with an organization like this, community and member engagement is so important. That's just a snapshot on the left of our community data dashboard for the region. It's very interactive. Ballot Health invested in the purchase or contract for the Unitas community referral technology platform that now member organizations and other organizations working with the Strong ACC in our region can sign on as network partners for free. So our clinics, ETSU Health, are in the process of signing on to use this technology. And what this is going to do is help us use a technology solution now that we are aware and we're identifying adversity and social determinants and behavioral health needs. This will allow us to be more easily able to connect our patients and clients to community resources and then track outcomes about those, communicate about those. So finally, what's next? I think the only other thing I didn't talk about on this timeline was caring for motherhood. So, you know, again, this is just kind of taken over, and there's so many areas that we can apply this model of trauma-informed practice. So one of our newest areas of focus is for our moms. As pediatricians, we actually engage with moms, particularly if they have young children, much more frequently than their providers do because their kids have to come for checkups so often. In our state, these priorities have been identified for preventing deaths in moms during pregnancy and during the year after birth. So that really healthcare providers need to obtain a trauma-informed history that can guide their interventions and be educated. So Caring for Motherhood is a new program that we're developing to help with that. Finnegans Challenge is something that the Strong Brain Institute is partnering on. Our former athletic director at ETSU and his family has started a nonprofit to help improve resources for children born with birth defects. And I can say as a healthcare provider that we, unfortunately, particularly with children with birth defects and chronic illness, we are traumatizing, right? And so he and his family reached out to the Strong Brain Institute to mobilize a group of experts to help contribute trauma-informed resources and education, again, to help serve families with kids born with birth defects. Our regional children's hospital is continuing to grow, and now starting this year, we have integrated behavioral health in our subspecialty clinics, and we're developing a complex care navigation program and plan for using trauma-informed approaches and all those resources that I mentioned, again, to serve families with children who have chronic medical issues. We are also starting a podcast series. You know, everybody's doing it, especially all the time that we had to stay home during COVID, right? So this is not going to be solely focused on ACEs, trauma, and resilience, but that will definitely be a component. So Growing Stronger Together, we only have a rough draft of our podcast art, a podcast for people who care for kids. Just wanted to do a shout out to the American Academy of Pediatrics. Our group has participated in their trauma treatment and resilience initiatives through a number of Project Echo trainings. They have a new website with wonderful professional tools. So if you're a pediatric care provider or you know one, check out this website. They've got some trauma-informed practice, education resources and tools, very nicely designed for the pediatric setting. So in conclusion, I've talked about pediatric primary care, academics, as well as our community and trauma and resilience informed initiatives in Northeast Tennessee and the surrounding region. We've come to start calling ourselves the Appalachian Highlands. And just to conclude with some of the lessons learned that I've learned, that this team-based care is really valuable and can accelerate progress in awareness and interventions for sustainability purposes. We have been able to mobilize our payers to some extent, and that's been valuable. Leadership is so important. I guess some leaders are born, but some leaders are made. And I think the work done to continue to educate and increase awareness, including with our leaders, is really important. There is great potential in collective impact. And so I look forward to seeing all that our strong, accountable care community can do in our region. And then again, as academics, we recognize the need for continued research and evaluation in this area. So I have my contact information there. And like I said, I'm happy to send these slides on to you, Jesse, if anyone's interested. So thank you so much.
Thank you, Dr. Schetzina. There is certainly interest in sharing the slides. And as always, we will share in our follow-up email the resources. So please do share those along for our friends at CityBlock as well, who we're about to get to. For you as well, if you're able and willing to share the slides, would love to share those with our audience following the call. Moving right into CityBlock, our presenters, Dr. Alina Schnacki-Mall, is a social epidemiologist and health service researcher. She's currently a postdoctoral research fellow at the Urban Health Collaborative in Drexel's Dornsife School of Public Health and consults for CityBlock Health. Scott Heiser is an MPH. He's the head of product strategy at CityBlock, where he leads CityBlock's payment innovation work to help the company enter into new population segments with new products. The presenters will cover CityBlock's approach to further investing in trauma-informed care and evaluating the impacts of a multi-level trauma-informed care intervention. So with no further introductions necessary, Scott, Alina, please take it away.
Sure. Thanks so much, and great to be with you guys. Let me just pull up the slides. All right.
Can you all see the slides?
Yep. That's great. All right. So thanks so much. If we can go to the next slide. Great. So CityBlock is a 4-year-old company, and it was founded by 3 folks who came at this problem from different places in healthcare. 2 who work together at an integrated duals plan in Massachusetts called Commonwealth Care Alliance, which is both a payer and provider. And the other co-founder was employee at Google. And what they recognized was, low-income populations were really not being well served by the existing delivery system, and nor by, the kind of patchwork social safety net that's, part of the lives of many low-income and disadvantaged communities. In addition, as our previous presenter, eloquently highlighted, healthcare is actually very much mediated by social factors. And in fact, the way that we pay for healthcare fundamentally doesn't account for those drivers of health. And then lastly, technology really hasn't been purpose-built for these populations in order to unlock more access to care that is often needed in order to address some of these nascent social gaps that occur for our populations. And as a result, disparities continue to persist. And so, next slide. We brought to bear some of the nation's leading investors to try to take on this problem. And really the mission of the company is to try to take sort of healthcare, technology, and people and improve outcomes for marginalized communities. And to do that, we build, a scalable care delivery model and technology stack that is really trying to bring integrated care across primary care, behavioral health, and social care, 24/7, 365 for the populations that we serve. And so how we do that is we take on total cost of care risk for high-risk folks in Medicare, Medicaid, and dual eligible populations. And we are able to invest significant amounts of time and talent and resources to help structure interventions that matter to people's lives. And so next slide. We're in 4 different markets today, well, actually 5. North Carolina is live. We work with health plans to take on full risk agreements and provide both clinical and non-clinical support. And our sort of member segments include dual eligibles, Medicaid and Medicare Advantage, as I mentioned, but also we also have populations in the commercial market, as well as HARP in New York. And in the near future, we'll take on other lines of business as well. Next slide. And so how we do this is not just through technology, it's not just through in-person care. We use a mix of clinically prepared and non-clinically prepared staff, which include multidisciplinary care teams with physicians, nurse practitioners, nurses, as well as licensed social workers and behavioral health staff, in addition to a role that we call the community health partner role, which is a lay member of the community in which our members reside. These are really part of the care team, even though their roles are fundamentally non-clinical. We provide, as I mentioned, integrated primary care, behavioral health, and social care to all of our members. And it runs the gamut from, in-office preventative visits all the way through accompaniment to drug court appointments and things like that. We do it through a range of different tactics to reach members wherever they might be. We have a community presence often, so we have physical locations where members can come and receive care and connect with the care team. but we also do, virtual care, as well as care in the home. We work also with our technology stack to really influence how members are able to access our care, but also how we're able to understand what's happening to them. This allows us to, drive interventions that we know are effective at preventing downstream complications, which are really important for our contracts to be performing. Next slide. And so when we think about, how to take risk on these types of populations, what we have to do is really understand what happens to a member. And that's, of course, very consistent with deeply understanding a person's complex personal history. And so when we're assigned a population from our payer partner, we try to reach that member and conduct a very detailed assessment. And based on that data, what we're able to construct are what we call clinical phenotypes. And those phenotypes correspond to the kind of interventions that are really effective at moving the needle on outcomes for these particular populations. And of course, depending on an individual's experience and what matters to them, those interventions need to be tailored appropriately. But what we tend to see is sort of the phenotyping falling into four main categories. The first is kind of a socially isolated and unmanaged bucket, where a majority of the spend that's occurring is sort of about a lack of connection to the community. And what we find is that a CHP-driven intervention that allows them to be connected to the right social care actually does result in reductions in social admissions to the ED or the hospital. The second bucket is a kind of polychronic and undermanaged population. So pretty significant complexity on the medical side that takes a lot of coordination and is often not well documented or understood by the care team itself. And so we know that being able to provide that one-stop shop of some of the things that are needed for the comorbid member is really about addressing some of those underlying health conditions so that they don't exacerbate into something downstream. Third, we see significant prevalence of serious mental illness in the populations that we serve. And we find that often addressing an underdiagnosed behavioral health condition with the right clinical interventions, as well as the other pieces of our care model, can help address inpatient behavioral health admissions, as well as improvements in physical health outcomes. And then fourth, we tend to see quite a bit of serious and life-limiting illness. And so we do shared decision-making and deliver both home-based primary care as well as palliative care interventions that allow people to have improvements in quality of life and reductions in the end-of-life utilization consistent with their wishes. So next slide. So as I mentioned, we do these detailed assessments on our members to really understand what sort of things are happening in their lives, and how do we then structure a care model to be able to deliver those interventions to people in a personalized way. And what we pick up is very consistent with some of the trauma-informed care interventions that were discussed in the previous presentation. We see exposure to violence, we see unsafe housing, we see low social support. All those things are sort of factoring into what are the things that we need to do for our members. And so, at the bottom of this pyramid, we think about this is what happens for every member, and we make sure that they are going to receive this routinely. Things like assessments, resource awareness, and motivational interviewing are part of that package. For more targeted interventions where we see an emerging risk of something happening, we see real benefit in trying to support a member to actually avoid that downstream complication. So things like accessing entitlements or other things that we can actually help them solve with the care team that we've assembled fit into this category. And then, at this top of the pyramid, we see people in crisis who need very acute response in order to address a nascent and emergent need. Things like a crisis housing intervention fall into this category. So next slide. So, when we actually look at a real member and sort of relate that to the clinical phenotyping for her, what we found for Sonia was that she had some significant underlying behavioral health needs, and she was seeking connection and often finding it in acute settings. But those social gaps as well were not being addressed as part of her previous care plan. And so when she came to CityBlock, we were able to connect her to a food pantry. We were able to get her housing. We actually got her permanent housing during the respite stay. And that was facilitated by our community health partner, her behavioral health provider, as well as the primary care provider. And she was engaged in these multiple modal interventions, both phone calls and texts with the CHP, in-person visit with a primary care provider, and virtual visits as well. And then our community paramedicine visit at home, which diverted a ED visit. And for her, we saw 20% lower reduction in hospital use compared to a baseline period, and then actually 24% reduction in PMPM costs and 0 ED visits since April of 2020. Next slide. And so, a bit about how we think about structuring a care plan to take care of members, who we are assigned by payers. And the first is that we have an assignment of a set of beneficiaries, and we need to then understand what is happening to them so we can prioritize our efforts. The second is we need to find them and we need to engage them, build trust with them so that we actually have a surface area to impact what happens to them downstream. And so we do that with our care model, but we also do it through the development of escalation and triaging, which allows us to structure the right care pathways depending on what are the set of conditions that are part of that person's life. And that can run the gamut of things like maternity care, but it can also include things like housing. And then underpinning all of that is technology and collaboration with teams that help us understand what are the right things to do for the right members at the right time. Next slide. And so the way all this works is because we are a risk-bearing provider that has up to full risk with our payer partners. We're able to make double or triple the investment in primary and behavioral health, and actually invent basically this new class of care that's not billable called social care, only because we are paid by a health plan to increase that amount of investment, and we're at risk for the outcomes on the back end. And so in a traditional PCP setting, what we see is 2 to 5% of spend of $100 of the spend is associated with primary care and behavioral health. But after CityBlock comes in and it takes assignment on that population, we try and invest double or even triple that amount. And that allows us to finance all of the interventions and teams associated with the provision of these types of interventions across the domains. And when we are successful at doing that, what we find is we actually observe 20 to 30% reduction in inpatient stays, as well as improvements in quality and other service categories as well. And the result is that in that green area of the graph, we capture the difference between the prior year's spending and the current year spending as part of our contractually agreed risk sharing with the payer, who also benefits from our efforts. Next slide. And so, how do we think about a member journey in providing this type of care in a trauma-informed way? The first is that we would identify a member, and based on their claims history, we would see that they had a diagnosis associated with trauma. We would use a trauma-informed approach to doing outreach, ensuring that any potentially triggering questions would be addressed very carefully. And all of our staff are trained to listen, to be empathetic, to validate emotion and with compassion. We then develop together a care plan, which we call a member action plan. And that's really about building shared decision-making and co-designing a care plan that is reflective of John, in this example, his own goals. We also know that maintaining appropriate boundaries is really important part of providing trauma-informed care. We do provide integrated clinical care, and we know that providing a welcoming environment that's non-threatening builds psychological safety and allows us to get the surface area to address the key needs of this beneficiary, which include many drivers of health. We've talked about this so far. We know that team-based care is absolutely essential, and that ensuring that we have trauma-appropriate language when working together to direct our beneficiaries to evidence-based treatments actually builds trust and engagement throughout the process. We see that support through transitions, which can occur as a result of trauma, are really important to build in a trauma-informed way. So we collaborate closely with external agencies to ensure that we have close follow-up care associated with any type of a transition. And then lastly, we say, you need to call us first. We can help you through the urgent, emergent issues that you might be feeling. We can get to you wherever you might be, and we recognize when there are signs of trauma, and help to de-escalate situations for our beneficiaries to keep these beneficiaries healthy at home and avoid downstream acute utilization that is not consistent with his goals or ours. The next slide. And another real story from some of the work that I do at CityBlock, thinking about a maternity-focused payment model. So we had a member who's 33 years old, who had 2 prior pregnancies before we connected with her. We saw, based on claims history, that she was pregnant, and she was also COVID positive. She could not get in touch with her OB, and she was terrified. And when she reached out to us, we discovered that she had a traumatic first exam with her gynecologist as a child, and as a result, she was quite terrified of experiencing another event like that. She sort of rejected some of the traditional and recommended prenatal care, and she, was quoted as saying, being mad at me. She didn't want to engage with her traditional providers because she felt that they would be mad at her because she didn't listen to what they say. And so what we did that was trauma informed was, we gave the member control to set boundaries. We allowed her to guide us through what worked for her so that we could build trust and engagement. Video only on the virtual visits that we did, only when she wanted it on. She invited us to do a home visit, provide accompaniment and support for the medical visits if she asked. We built in shared decision-making with her so that she understood that her preference for an elective repeat cesarean contained risks and benefits. And then we also provided her counseling to understand she was empowered to decline routine cervical exams at her provider visits. We ensured that she had a referral to our behavioral health supports, which was really important to address an underdiagnosed anxiety and depression issue, which of course are frequent sequelae of trauma. We knew that being able to be flexible and meet her where she was really, really important. During hospital care, providing doula support that was in person and interdisciplinary team huddles that addressed those nascent needs was really important. In addition, being there for her during the postpartum period. where many of these vulnerable beneficiaries fall away, was critical. And so what we see with this member is that after a year under our care, she's requesting preventive care. She's asking for family planning. She was completely skeptical of these things to start, but in the in the context of a provider that is known to her, it's quite acceptable and desired. And this member continues to be under her care today. Let me turn it over to Alina.
Thanks, Scott, and thanks for having us. So I'm going to take us a little bit to a forward-facing place. So Scott talked a lot about the ways that I think trauma-informed care has been kind of integral to the way that we think about the CityBlock care model in general. I'm going to talk a little bit about where we're going and how we're thinking about kind of formalizing trauma-informed care practices within the organization as a whole, and then also some kind of intensive programming. So to take us back from a little bit of a research perspective, I'm a researcher, so I have to go there. And I'm sure I don't have to, say too much about this for all of you, but there are massive health impacts of trauma, right? At a really simplified version, there are long-term high levels of stress and reactivity to perceived threat that occurs because of exposure to trauma. And that leads to a whole sequelae of health challenges that can kind of directly lead to higher healthcare utilization, whether that is primary care use or acute care use, so emergency department use and ED use. And there's research that suggests that many of the health conditions that we try and treat are really resistant to trauma because we fail to treat the underlying trauma. So if we go back to this value-based care concept, right, if we are trying to address improving healthcare outcomes and population health, improving the quality of care and reducing costs, we won't be successful in those places unless we're addressing this underlying trauma in many ways for many patients. And so it really builds into this value-based care idea that trauma is a core concept in order to be successful in this space. And then when we think about the populations that CityBlock serves, we know that there are high rates of trauma in the CityBlock population and in populations that are similar to CityBlock. And we know that beyond that, not all of it shows up in claims data. Much of it is undiagnosed. And so that's an important factor. We also know that this isn't, trauma doesn't happen randomly or due to chance. So we know that vulnerable populations and marginalized populations suffer from higher rates of trauma because of structural vulnerabilities. And those are related to systemic racism and socioeconomic oppression that intersect in ways that magnify the risk of trauma and that also make it harder to address trauma. And then we know that healthcare is part of that process, right? It is often within healthcare settings that we are actually creating trauma or reigniting trauma or recreating trauma for folks. And so it's important for us to really think within our healthcare setting, what are we doing? How do we address that? And that's exactly what sort of motivates CityBlock to say, that trauma-informed care has to be a core part of our model and our care practice. But we also know that as all of you are here, there's been lots of focus and shifts towards in policy and practice towards trauma-informed care. But specifically within the primary care space and in the value-based care space specifically, there aren't a ton, or there's a lot of opportunities and gaps to build validated models that are scalable elsewhere. So we know that there are some models out there, but that there's kind of places to fill in where we can really say, okay, well, what's a validated model that we can use here? And then we can show other places and then we can really scale up. So all of that brings us to a place of thinking about CityBlock, thinking about how can we use the resources that we have in the space that we have to start building out some of these more models and formalize and validate and evaluate a trauma-based organization and then some specific trauma-based programming. And so as I said before, we know, why would we do this in the CityBlock space? There's, there are really high levels of trauma in the population. We know that the CityBlock has existing trauma-informed care practices. There are trainings that all providers receive on trauma-informed care, right? Our spaces are designed particularly with trauma-informed practices in mind. The core clinical model, as I said, are really based on trauma-informed models. All the assessments and referrals and team-based care models are really related to trauma, addressing social determinants of health. But there's room to grow. There's room to improve. And I think in particular, there's room to think about how do we not just provide trauma-informed care, but how do we become a trauma-informed model as an organization? And then again, as I had said before, I think this is really building into the value-based structure. It is kind of core to have the value-based structure work is to address trauma in the population. And the idea here, and the reason that we think it is worth spending the resources and the idea on, is that it effectively helping members address challenges with effects of trauma can improve functioning, it can improve population health, which then can reduce acute utilization and potentially lead to reductions in total cost of care. Now, I would stop as a public health person, I would say improving trauma is important in itself. Improving population is important in itself. But in order to build models that are replicable and that other places want to scale up and employ, we also understand that there has to be impacts that we show on total cost of care, because that's really how we get these models to scale elsewhere. So as CityBlock is really thinking about this, we're thinking about really formalizing this process, building on many of the kind of existing best practices for building a trauma-informed care organization, right? And so here, I'm not going to talk through each of these, but many of these kind of classic concepts of how to build a trauma-informed care model. And I'll just say what we're thinking about doing and where we're going next is really building a kind of multiple and complex, multi-level program and intervention with the intention of avoiding any re-traumatization that emerges from members and for employees, right? And so it's really trying to build on existing research and best practices, and then build in some new kind of creative approaches and the challenge normative understandings of trauma and treatment within the behavioral health side, to kind of build a program that works and then show demonstrable impacts on member health and member outcomes. So just to get a little detailed on this, we're thinking about a multi-level intervention. So first thinking about how do we make sure that we're a trauma-informed organization? Again, building on the SAMHSA model, building on UCSF, or I'm sorry, not UCSF, SF, Department of Public Health model of becoming a trauma-informed organization. We're thinking about really how do we do some of these kind of these interventions around having trauma-informed organizational goals that through full organization, not just the care teams, but the full organization are really driving towards. How do we have clear metrics? How do we have repeated trainings across the organization? Not a one-off when you get first at the organization, but repeated trainings over time. How do we have signage and tailored messaging? How do we have champions? So how do we really make sure that we are a full trauma-informed organization? And then how do we also have a behavioral health intervention that is focused specifically on the highest risk population? And so I'm going to take us really quickly to this bell-shaped curve. Folks that are in public health might recognize this as Rose's prevention paradox. So this is the idea essentially that for any health outcomes, so let's look at trauma on the kind of x-axis, we have a range of trauma experiences. And so most of the population is probably in the tall part of the bell curve. The majority of the population is there, but we also have a small section of the population that's the really high risk trauma area. So we could think about that as sort of chronic trauma. And what we want to do as an organization is to say, we can't just treat the highest risk population. Yes, incredibly important. But what we want to do is we want to shift the bell curve over. We want to reduce the trauma experience of all of our members. And so we really want to, and that's what that environmental intervention is about, right? Including all of the existing practices and the behavioral health interventions we already have. How do we reduce trauma exposure in the CityBlock population for everyone, while also building in really specific programming around the highest risk populations. So it's kind of this combined approach that we're really thinking about driving towards. And then how do we validate all of that? How do we use the existing resources that CityBlock has with robust data infrastructure, with experience, with evaluation, to make sure that we are both programming, designing, implementing, and validating this to become a model for elsewhere. So that was just a little kind of forward facing to think about. And I thought it was useful to kind of frame around how do we think about the importance of trauma-informed care within this value-based space, and where can we leverage the resources that exist because we're in value-based contracts to really move forward and kind of contribute to the field in this space. So I will stop there.
Alina, Scott, thank you so much. That was incredible. We will jump right into Q&A. We have it looks like we may go a little bit over. I hope that we're all able to stay on for a little bit longer, but this is, one of my favorite parts of the CTIPP CAN calls is what I like to call Q&A ping pong, where we go between our presenters one at a time and just start chipping away at our Q&A. So to go back to Dr. Schetzina to start, how did you come to the read and play idea, and can you expand on why reading and playing are important from a healthcare perspective?
Our practice had experience as having a reach out and read program. So we'd been for several years giving out developmentally appropriate books paired with advice on how to share books with your child for infants and young children. Really, it was a trainee. That's an advantage to being in an academic setting. You have young minds with great ideas. She came to me, one of our PEDS residents, and was really frustrated with the behaviors that were sometimes ingrained in her teenage patients and in families, and said, can't we start earlier, like at birth, talking about health behaviors? And then we were able to apply for, it was a Healthy Active Living grant from the American Academy of Pediatrics. So really it was that experience, a trainee, an opportunity. And, you know, as pediatricians, we recognize the value of play and saw an opportunity to engage young parents in how to play with your kids, and saw that as a need actually in our patient population.
Thank you. And just want to acknowledge Dr. Schetzina, that I have been mispronouncing your name, and I apologize for that. But
I accept all kinds of pronunciation. It's a tough one.
Just got that note in the chat, so wanted to correct myself there. Over to CityBlock. So sort of a threefold question here. So first of all, Alina, if you were able to go back to the slide for the portion of this Q&A so that our audience can look at it a little bit deeper, where you were talking about the trauma-informed strategy specifically, you had those 2 blocks. We had a request for that slide to be up a little bit longer. So first, thank you. So are you willing and able to share some of the resources and evidence-based practices that inform CityBlock's approach to training staff and implementing organizational changes? And can you share your PowerPoint slides for the follow-up email, and anything in the resources as well is part 1 of a part 2 question here?
Scott, please jump in here. You know, this exact slide I did not make, so our behavioral health provider made, but some of the resources that we've been thinking a lot, I mean, that we used a lot were some of the SAMHSA trainings. The SF Department of Public Health had a really incredible slide I didn't include, but about thinking about how you shift to become a trauma-informed organization as a whole. And then I would actually have to ask some of our other providers who designed the trainings around that. I think we may be able to share some of the slides, but not all of the slides. Scott, is that right?
Yeah, we just need to check with our legal team, but we'll get back to you for sure.
No problem. Appreciate that. And then, so on to like the more direct questions about the presentation. Is the total cost care savings in your slide a theoretical example, going back to Scott's portion of the presentation, or do you have actual historic data showing such savings?
Yeah, so we have, as I mentioned at the front of the presentation, we've been in market with some of our first cohorts since 2018, and we've begun to see really heartening results as part of our experience with those cohorts. And as we take on more and more cohorts, the longer folks have been with CityBlock, the more impact we see on total costs of care over time, which is consistent with the literature on value-based payment. The interventions obviously take some time to pay off, but certainly do show in our own internal data.
That's great. Dr. Schetzina, we'd be interested in hearing how the selection of the backbone agency that you were talking about went, and did you choose for multiple options, or was there an obvious choice?
So the health system that was newly created from the merger had the resources as part of an agreement with the states of Tennessee and Virginia. They had to justify the merger by promising to improve the health of the population. And so a population health department was created in the health system that hadn't existed before. And this was one of the early initiatives of that Department of Population Health, was to take steps to develop a strong, accountable care community. So they came into it early on, initiated it, had resources, again, because of the merger, to support it. We've had other backbones. United Way of Southwest Virginia is one of our other backbone organizations right now, but Valid Health is, and I think will continue to be the funder, a primary funder. At the same time, we do function as an unincorporated independent organization. The Leadership Council is the decision-making body. But good question.
Thanks. Alina, for your care model, is it a social worker that reviews the individual clients? And can you expand on what social care is?
Sure. So it's often actually the whole team. You're doing a whole team huddle for new members. So it's the community health worker, which some community health workers are social workers. Most are not clinically trained at all, but social workers may be behavioral health providers. So you're doing a review of new members with community health worker, behavioral health provider, an NP or an MD, and a nurse generally. So it's a full team that are getting to understand the new members and try and think about care planning together. And the second question was, I'm sorry.
Can you just what is social care?
So we think about a social care as sort of the social determinants of health. How do we think about all the things that happen outside of the healthcare system, but that are deeply integrated with why we use the healthcare system? So we think about social care as addressing things around food access, housing, social support, transportation, all of those factors that 80% that Dr. Schetzina talked about, that really both influences behaviors, but that is really so determinative of who we see as sick and who we see as well, that we actually end up interacting with in the healthcare system. So it's really trying to address the things that often standard primary care can't address, but we can because we have the time and the resources to address those factors.
Thank you. We have time for one more question for each of you that had come in. Recognize that there are probably some more out there, but already over time. So just want to be as respectful of time as possible while also going over as I say that. So for Dr. Schetzina, can you share more about your rationale for screening for ACEs? There was an observation that many experts, including Dr. Anda, do not recommend screening for ACEs as the tool was used in population level studies. And so can you just expand a little bit on that for us?
Yeah, no, I agree with you. And I have to admit, I am more educated about that research now than I was when we wrote that grant. At the same time, we were looking for funding to serve our patients, and there was interest in developing screening for healthcare settings and evaluating that. And there actually still is in our state. Nadine Burke-Harris is the other answer, because I saw her in a billboard in Chicago, heard her speak at the American Academy of Pediatrics conference, and we trained together in California. And that got my attention, the work that she was doing, and we did end up adapting that ASQ screener from her center. So it was also sort of a personal connection. We learned a lot from the process, and we were very careful about how we had conversations. We had training, we had scripting. The fact of the matter is, there's only so much you can jam into a 10 to 15 minute well-child visit. And so we have since then revisited our screening. We're revisiting it again right now. And at the moment, we only do the ASQ screening with the parents or caregivers in our Baby Steps program. So that's the program that's for infants and kids who had prenatal drug exposure. Again, with that special population, our care coordinator with the counseling background does that. And it's really just a way to engage in conversation and get to know those parents and caregivers a little bit more to help support them. So, and we do, I saw another question just about reimbursement. in the past, we were not being reimbursed for screening for social determinants, and we are more so now. So the reimbursement from our state Medicaid program has improved in Tennessee.
Thank you. Alina, how does CityBlock integrate with local health and social service organizations?
So CityBlock, first off, before going into any market, does a kind of robust community health and needs assessment that includes doing early outreach to local providers, community-based organizations, social service providers, local government, et cetera. And then there are specific folks whose role it is to engage with community service providers to try and figure out how we can refer back and forth, and then work with organizations like Unite Us to help with that referral process. So there's a pretty robust system of trying to make sure that we're working with existing resources and existing organizations.
That's great. Thank you. One final question, if you have time for both, is to what extent were consumers involved in the creation of what you've both put together?
So I will say yes to that. In a lot of instances, we did have a group that was based out of our children's hospital of parents and caregivers that has served as an advisory group on a number of different projects over the years. We've had the goal to also develop something similar out of our pediatric clinic or out of ETSU Health, and we've not had the capacity to do that yet, but that's so important. So yes.
CityBlock has, throughout various stages of the organization and the care model build, been engaged with members, which is our term for patients, particularly the pregnancy model was really built collaboratively. So many parts have kind of integrated patients or consumers throughout the process. And I'm sorry, I have to jump off.
No, thank you for staying on. All good. Thank you for everybody who's still on. Just a quick final plug for what I was saying earlier. The 3 links that I shared, please sign up and share information on the workshop series that we're putting together. Our podcast, Cultivating Resilience and Trauma in Schools, is out. Please give it a listen and share that with others as well. And a quick plug that we are looking for communities that have leveraged successfully American Rescue Plan Act dollars. So if your community or state has been able to use ARPA dollars for trauma-informed initiatives, please send me an email at the email in the chat. And just one more thank you to the team at CityBlock and Dr. Schetzina and others from the Strong Brain Institute for the presentation, as well as all of the work you do. Really appreciate your time today, everybody who was on the call. Thank you as well for the work you do and for being with us. Next month, we have presentations from the CDC and the National Governors Association. So that will be, again, the 3rd Wednesday of the month. I believe, and I will check really quickly, that is December 15th. And a quick calendar look shows that that is indeed correct. So December 15th, 2 to 3:30 p.m. Eastern Time. Hope to see you all there. Be well until then. And again, thank you so much.